Okay, we're going to get started. So good morning or good afternoon, depending where you are in the country today. Really pleased to have you here today for our webinar, Medicare Direct Contracting, What Providers and Payers Need to Succeed. So I'm going to go ahead and get it kicked off. If we can flip to the next slide, please. So I'm Alan Miller with Cope Health Solutions, and it's a real pleasure for me to get to spend time with all of you and some really talented speakers. So the folks we have with us today, we have Lesley Reeder, and Lesley is an actively registered nurse, also has an MBA, so she's got the clinical and business side. She's one of our vice presidents who works nationally with health plans and providers around clinical, health plan management, quality, NCQA, those kinds of areas. She's got over 20 years of experience in value-driven healthcare. She's been serving highly complex populations as well as your regular Medicare, Medicaid, commercial populations. Really deep expertise in quality care models and overall population management, again, particularly for some of the high needs type folks that Medicare is envisioning with this program, for instance, in one of the areas. And she's really worked with payers, providers, government, and community. So really pleased to have Lesley with us. Rich Lipeles. Rich is the Chief Operating Officer for Heritage Provider Network, which is a national medical group, is an understatement. It's one of the largest medical groups, IPAs, probably maybe the largest private one in the country, about 1 million members under management, 4 different states. They have a California restricted Knox-Keene. So Richard has over 40 years of experience in leadership across healthcare and entrepreneurial companies. He was actually the president of Pacific Care of California, and then their EVP, overseeing numerous states nationally for their managed health care division prior to going to Heritage. And he really brings a very deep expertise and experience with provider capitation and risk across all different lines of business and large populations. So really pleased to have Rich here for that. And then Dave Weathington. Very pleased to have Dave with us today. Dave is just transitioning out as the Vice President of Healthcare Operations at Clover Health, which is a national Medicare Advantage plan that's also launching April 1st as an ECE. Dave is actually going to be starting soon at Anthem as an executive in their value-based payment area. So excited to see where Dave and Anthem go with this. He's got over 20 years of experience with Medicare and value-based payment, fee-for-service, Medicare Advantage. Dave has just got a wealth of experience with anything related to Medicare and therefore has a really, really interesting view and insights on this program. So Lesley, Rich, and Dave, thank you so much for being here today. So a little bit of housekeeping, just to kind of orient everyone to how these work. So we do have a Q&A feature in the Zoom, which you can see in the screenshot. And if you enter your questions there, we can answer them at the end. We also will be sending out a written Q&A document. So if we don't get to your question today, we will send you a written answer to your question. It'll go out to all participants along with a PDF of the presentation and a link to the recording. So don't worry, every question will get answered. We may not have time today. You can also email us questions at info@copehealthsolutions.com. And then after the presentation, we'll send you a brief survey, and we would really appreciate your help with that because it helps us, obviously, to improve these over time. So we have a pretty packed agenda today. We will try to get some time to address a couple of questions at the end. But again, even if we don't, all the questions will get answered in writing. And we've found that folks tend to find that helpful because you just get them all answered and you can ask questions about the written responses. We're going to talk a bit today about the opportunity of Medicare Direct Contracting. What is this? Why am I interested? Why should I be interested or not? And then we want to look at it from a provider perspective. So what does it mean for physicians, for medical groups, for providers? What does it mean for payers, health plans that are looking at this? And then, so what does it take to be successful? What do you have to be thinking about if you are a payer or provider and you want to do this? What is it going to take to succeed? And then finally, we'll wrap it up. Again, get into maybe a bit of Q&A, and we'll get the tape out to you all. So let's talk a bit about this really interesting demonstration. Someone asked in a question, is a pilot? Well, it is a demonstration. It's not yet built into the long-term Medicare plan by CMS. Clearly, this was something the last administration dreamed up, but that is being continued with the current administration so far as we can tell, even beyond the April 1st starting point. What does this do? This is an opportunity to gain access to more of the premium dollar. So if you're in Medicare fee-for-service today, you can bill for what you see. But this is an opportunity to get access to the bigger premium, all the money that gets spent on this beneficiary across all the different areas of the care continuum. It also allows you to engage with Medicare fee-for-service beneficiaries in a different way, different than you were allowed to, for instance, through the shared savings program. And finally, it allows you to align physicians and other providers differently. And one of the themes of this will be potentially you can, of course, leverage that ability to engage with beneficiaries and align providers across your other value-based payment agreements and lines of business as well, whether you're a payer or a provider. This is still a fee-for-service program, so what's important to remember is that you can't deny care. There is no out-of-network. You do have an opportunity to create your own network. You do have an opportunity to get folks aligned, but at the end of the day, if you are a Medicare fee-for-service recipient, you can go to any Medicare provider. So that's an important thing just to keep in mind as we get going. There are a variety of flavors in terms of how you can engage in this. And so basically think of it as a bit of a grid. There are the types and number of population you're going to engage with. That's the decision of being a standard or a high needs or a new entrant. As a standard, you have to have 5,000 attributed members, not unlike shared savings. As a high needs, it's a much smaller membership, and it's also for people who are more dual eligible, really high needs, complex members who take more care management and focus, and so it's a smaller membership. And then new entrant is for folks maybe who haven't had as much Medicare experience in the past, don't have as many attributed members, and so you can actually start with a smaller number and build toward the 5,000 over time. Finally, there's whichever you choose, standard, high needs, or new entrant, there's global or professional, and that's your risk level. If you take professional, then you're only taking half the risk, upside or downside. If you're taking global, you're taking all the risk. Now, there are some risk corridors, so you're not really taking all of the risk or getting all of the shared savings, but the risk corridors are pretty reasonable. You're certainly getting first dollar, which is really unique and interesting about this. And then finally, there is another decision you have to make, which is if you want to take primary care capitation. If you're in professional, that's actually your only option, is to take primary care capitation. You don't get to choose global. Or if you are in global, you can choose to take either primary care capitation or global capitation. So those are the flavors of what this is and how it works at a high level. So what's interesting too is to think about, well, how does this fit with my value-based payment roadmap, my other agreements? Where does this fit? And the way we like to look at this is, what's the financial risk-reward ratio? In other words, how much money is on the table here for me to get access to? And then at the same time, if you look at the x-axis, what do I have to build? What do I have to have available? What's the investment really for me to be successful in this? And so if you look at the way this is laid out, the general story here is that, look, if you have your own health plan, your own self-insured employee health plan that is deeply aligned and integrated with a closed network, that is the kind of the top. But it requires a lot of infrastructure because, of course, you have to do all your own claims and and everything else. You have to have a very specific, complete network. You pretty much have to have everything, but you also have maximum opportunity to access the premium because you have it all. Medicare Direct Contracting, the reason it's not at the exact same level is that you do have access to all of the financial maturity. You don't necessarily have to build all the exact same infrastructure, but actually what's important is you'll probably need to be very, very focused on your care management, your medical management infrastructure, because you can't do So it's not that network and these other things aren't really, really critical. You really need to think about the fact that while you're getting access to those dollars, you really have to invest in and understand engaging with your network, engaging with the beneficiaries, and being able to manage people, right, to help them stay healthy, and also being able to manage people to stay within a network that's operating on evidence-based medicine, because if they start bouncing around all these other specialists and everybody else they're allowed to go to, you could easily lose control of how care is provided. So one of the things we talk about that's really important here is being able to create a pro forma to really help you understand how you're going to be able to perform. A couple of other key things to keep in mind here as you're thinking about the opportunity, the financial opportunity. There is a 2% discount for global risk. Happy to go into that in more detail. If folks have specific questions on that, we can follow up with you. The other issue is that from a benchmarking perspective, because there's such a large geographic component, if you're starting with a population that's already higher cost in your geography, you can really be at a disadvantage. Whereas if you already have a lower cost population, you could be at an advantage. So it's not all about cost trend. A lot of it is about where you're starting versus your geography. And so that's just some kind of key things to keep in mind as you think about where this fits within your overall strategy. So what is the value? So again, why would I do this? What does this do for me? Well, one of the things this does for you is that, you know, we're in a country where the fastest growing population is old people, right? People over 65 is growing really fast. People who are therefore eligible for Medicare. There's certainly talk, you know, would the new administration potentially be able to reduce the age of Medicare eligibility? We don't know. It's possible. It's probably more likely than a wholesale redesign of Medicare and some kind of a new option. So what we're generally looking at is that one of the biggest markets in the country, Medicare, is accessible through this program. You can access the premium, you can engage with those beneficiaries, and you can create a gateway into a Medicare Advantage product, which traditionally, you know, for the last couple of decades, every administration has been a pretty consistent push to expand Medicare Advantage, to have more people engaged in that. The plans, everyone's kind of working off of a Medicare Advantage framework. So one of the key things, particularly for your provider, to think about is how does this align with your Medicare Advantage value-based payment agreements today, with the payers you're looking to partner with, and do you have a place that you want to have these members be able to sign up for should they get interested in a Medicare Advantage product down the road? Quality is very much better aligned with MA in this program. It's much simpler than, for instance, the shared savings quality program. It's very focused on patient experience and total cost of care. So it lines up with what it takes to be successful in risk, where you're really trying to reduce the cost trend. You get the chance that we've talked about to build that stickiness with members. You can align your providers. So as you look at your doctors across your network, they have lots of patients coming into their office. And the question is, how many of those patients that they have are people who are attributed through you, either their IPA or their CIN or, you know, their direct contracting entity or a health plan? What percent of their panel do you control? Are you responsible for revenue for them? The more of their panel you're responsible for, the more they're going to listen to you and engage with your care model. The more they're going to listen to you and engage with your referral plan. So this gives you an opportunity to go deeper with doctors' panels than you would if you didn't have access to this fee-for-service population. And that's really important with relation to physician alignment. You can align their funds flow methodologies across different agreements. So that's all. Well, we see those as being pretty good opportunities here. And then finally, because you're getting access to more premium and you can get shared savings, there's a little bit of cash flow help here. That should not be the reason you do this, because it all gets reconciled at the end of the day. But what you can do is you can leverage the fact that you're in another premium risk program to help fund your care management and your other population health management infrastructure to support your other value-based payment agreements. And with that, I'm going to make a transition and hand it off to Rich. So next slide, please. And Rich, it's all yours.
Thank you, Alan. Hello, everyone. Excited to be here and to talk about Heritage and the direct contracting. Heritage Provider Network has been around for about 40 years, started in 1979 in Southern California with Blue Cross as our only payer. We now have 18 health plans, and we have about 1 million lives overall in 4 states. We have continued to grow based on our focus on primary care physicians remaining independent. So we give the physicians an option to be successful independently and compete with the likes of Kaiser, or not have to go into a hospital foundation because they have access to these 18 different health plans, and they have the infrastructure that we provide to help them be successful. Our goal is to provide one-stop shop for these physicians, and therefore We have all product lines. We have commercial and Medicare, exchange, and seniors. And that has allowed us to have exclusivity with many of our primary care physicians. We continue to be a preferred full risk partner for health plans, and a lot of our growth has come from health plans that have had trouble controlling costs in a particular market and have done a block transfer to us to take care of that membership. And because of the success that we've had with these health plans, they've continued to look at new areas nationally for us to grow into. We are a mixed model in that we have 52 medical groups that we own, and then we have our IPAs and MSOs that we own and manage as well. Only about 25% of our enrollment is in our staff model, and our staff model is only in California. The fee-for-service revenues that are currently available, we are looking to align those, and we have been one of the pioneer ACOs. So from the beginning, we did look at alternative managed care models. In the pioneer ACO, we had 80,000 aligned beneficiaries in Southern California. I believe we were the largest nationally, and we have done next gen. And now we'll be talking a bit about what we're doing in Arizona and California. We do have a big investment in the infrastructure to manage the care, and we do have primary care physicians who have asked us to make our infrastructure available to their fee-for-service patients, and we haven't been able to do that. So at least with the seniors, this allows us to get alignment with the seniors in a direct contract, and we can then make some of these care management and population management programs available to them. Growth also gives us an opportunity to have more lives and therefore have more leverage with specialists and with hospitals. We think that over time will result in some of the volumes moving to Medicare Advantage. That was certainly our hope in the Pioneer ACO. We only had about 10% of the people move into Medicare Advantage after they had experienced some managed care in that program. So I wouldn't go into this with the belief that the majority of these people are going to go into Medicare Advantage, but it certainly is one of our objectives. In terms of the network, we do have a lot of information on specialists that we've been working with the rest of our million lives that we manage. We will be working with our primary care physicians. We like to say that we'd like them to refer to a specialty, not a specialist, so that the expectations of the patient are not in concrete. And that way we can move the patients to specialists that we prefer. We have believed that healthcare is local, and for that reason, we have 12 core companies. Each of the companies provides leadership for their geography, and that has worked well for us. We use a dyad of a physician and a non-physician for each of our businesses. We do use a technology across all of our businesses, and that's through Genic, a company that we've started, and it's our Q platform. The Q platform has allowed us to get nationally good results. For example, on hospital days per thousand, we have groups that are routinely less than 600 for seniors, less than 100 for commercial. And the technology is not siloed. It follows the workflow of a case manager or other practitioner. So it highlights the care gaps. It gives the case managers an actual to-do list daily in terms of what to focus on. We have continued to look for improvement, and that has often come from our other groups, which we don't see as competing with each other, but they do like to stand out as being the best. As I said, we have healthcare as local, so our branding is, we don't have any groups that are Heritage Provider Network. If you were to look at our companies, you would see High Desert Medical Group, Desert Oasis Healthcare in New York. We are Healthcare Partners IPA. Each one has a separate local name and accountability. That has resulted in our ability to act quickly, and we also are focused on providing decisions in real time. The technology that I had mentioned is homegrown. It actually was started for the Pioneer ACO, and then we incorporated everything we do in managed care into that, and that now is what we are making available as an independent company. The first slide, you saw that we are getting good star ratings with an average of 4.5 and risk scores up to 1.6 with an overall average of 1.34. Well, let me introduce David. He's going to talk now from the payer perspective.
Hey guys, welcome, and thanks for taking some time to listen today. As Alan had said, I've spent the last few years helping build Clover's national MA business, and really the last year focused on learning about direct contracting and what it takes to execute there. And I'll be moving over to Anthem next week, actually, to run a big chunk of their value-based business. You guys can read the slide, so I'll kind of hit the high points and move quickly so we have some time at the end if there are questions. But from a health plan perspective, particularly sort of dynamic health plans that are really interested in change, one of the things about direct contracting is it really continues to kind of move the payer and provider closer together, or sort of blur the lines a little bit more, if you will. And the way it does that, right, is by eliminating some of the traditional managed care type levers that health plans have to be successful. So really those would be utilization management. There is still risk adjustment, which is meaningful in this, but it's not as meaningful as it could be for an MA plan. And just really forcing success in this program to be based on care delivery, right? The actual management of member care. And this is in a really true way, because since the member is not opting into this program, you don't even really have, narrow network strategies, right? So this is, how can you develop a consumer-friendly program that also manages care effectively, right? I mean, that's really what Medicare is concerned about here is member satisfaction and cost. And if you look at their quality measures for year one, you can see they're really captured in there. So you can see these three levers: revenue growth and network. Those are really sort of, I think of them slightly differently as sort of the three pillars of the Medicare strategy are revenue, definitely, right? So that's both sort of managing premiums effectively, but it's also ensuring high quality performance, effective diagnosis capture, things like that, everything that drives revenue. Again, in this program, it's going to be predominantly cost medical expense management. Growth is obviously always very important, right? I mean, for any business, and particularly newer entrants into the arena, the idea to be able to rapidly scale, right, rapidly acquire members is really important. And for those of you who've worked with Medicare Advantage or in Medicare Advantage, you know that even fast-growing plans grow relatively slowly. So, we all know the numbers that we expect, another, 10 to 12% to be in Medicare Advantage over the next couple of years, but that's still a drop in the bucket compared to what this market is now open to us, right? And then finally, and perhaps most importantly, and you know, this is really interesting to me as I've done work in this, one of the biggest sort of value proponents for a payer to think about entering into direct contracting is the sort of the share of a provider's panel size that you will now have some control over, right? Be engaged with that physician group around, right? Particularly for newer, smaller plans who don't have as much market dominance. One of the biggest challenges to improved care delivery, right, or sort of improved collaboration with payers is they just aren't thinking about you. They don't see enough of your members on a regular basis to let the things you're trying to build with them and drive with them sort of be part of their thought every time somebody comes into the office. You know, we know in the markets, markets I've looked at, that, frequently roughly 30 to 35% of a provider's panel is made up of fee-for-service Medicare. And so if you think about 20% of that number would be Medicare Advantage, right? So another 5-6%, you're talking very reasonably, by entering into direct contracting, you could be up to 40% of many practices panel size. At that number, and with a shared strategy, so you're not engaging them in a direct contracting strategy and an MA strategy, but just a combined value-based strategy, all of a sudden you have their attention, right? So you really have the opportunity then to sort of drive any kind, whether it's quality-based, I mean, we can discuss all sort of the aspects of quality you want to drive through them, whether it's diagnosis, capture, and improved coding, and where it gets more important, and this kind of touches on I think a question somebody had posted is, and it also creates a lot of skin in the game for the provider about where they're referring patients, right? Because really all you're going to have in this through the preferred provider aspect of this is sort of a artificial network, right? That's based on the PCP behavior and PCP steerage. So, while we're excited because this creates revenue opportunity, this creates growth opportunity, we also think that sort of the reason we can be really successful, even though, I mean, this is a true risk demonstration, is by the improved engagement we expect with our panel. And it's funny, I'm taking a position at Anthem that specifically says value-based care. I actually, in my time working, I've worked with Alan for years, I don't love the expression value-based care because I think it creates sort of a sense of ambiguity or mystery by not being clear and precise, that's not really necessary. I tend to think that and I think most payers, as they view this thing, value-based care, right, is really a series of behaviors and focuses sequenced in the right order, right? And if you have the right series of steps and you execute against them effectively, you are going to get to a positive outcome, right? It should not be sort of a mystery where you end up, right? So from a direct contracting perspective on the payer side, right, the way I really think about breaking down these different chunks of success that you need, kind of follow on this slide, kind of clockwise from the top left, right? So first off, you absolutely have to optimize attribution, right? So that's both in really targeting providers who are both experienced with Medicare fee-for-service, but also, right, have a density of Medicare fee-for-service, right? The more density you have with those practices, the more effective you will be. The other thing, and for those of you who have worked on value-based contracts, whether it's the MSSPs or commercial value-based, what you find is frequently when you ask a provider to give you their list of attributed fee-for-service members, and then you compare that to alignment files from CMS, there's a lot of gap, right? Frequently what the provider gives you is much higher than what you see on the alignment file. That has to do with claims-based attribution and the fact that CMS recognizes cardiology and nephrology and OB-GYN and all of those as acceptable PCPs. So if you have heart problems, if you have diabetes and you're seeing your specialist more often than your PCP, that member may get claims aligned to them. So because of that, going into this, step one is making sure you have a really strong plan for voluntary alignment, right? You essentially just have to have that patient sign a form saying, yes, this PCP is my doctor. Once that's done, CMS will align them to you, right? And I think folks entering DC are going to be surprised how low claims-based attribution is. So once you get your members, right, how are you going to manage them? What are you going to do with them? Well, the first part is to make sure that you really engage those providers, particularly if you're working with health systems, if you're working with IPAs and ACOs who are in umbrella managing multiple practices. One of the folks is to make sure there's alignment at the leadership level, but then you're making onboarding, you're making training, you're making feedback really easy for all of those individual practices. I think what you find particularly with a lot of the newer entrants into the Medicare space, is that a lot of this can be done with technology, right? They're looking at sort of this provider engagement more as software as a service versus the traditional boots on the ground network engagement. That said, I do think it's very important that every practice, every NPI has a face, whether it's virtual or somebody they're seeing in person, but has an individual who's been assigned to manage their success, right? Because we have to, how does that provider even get information for us? How do we know they're going to engage with us as sort of we get to the last lever, right? While you're engaging your provider community, you also have to figure out how to strategically and intelligently make the fee-for-service beneficiaries aware of this program and aware of you as the direct contracting entity, right? I mean, nobody is opting into this program. Even if they voluntarily align, there's no obligation that's changed. So there's some limited marketing that can be done, right? So you have to form a Medicare-approved marketing strategy that has very limited telephonic outreach, but there are letters, there are other documents that you can use. So that's one. Two is, strategic use of the Medicare waiver benefit. So like the 90-day post-acute home care benefit, right? So to really, just begin a sort of a generic campaign about why would somebody want to engage with a doctor who's participating in this program, right? It's because it gives you benefits, supplemental benefits you wouldn't have access to if you weren't part of this program. And now, for people to be clear, they're not mandatory supplemental benefits, right? Every DCE can determine which of these waiver benefits they're gonna participate in. And then again, right, having more engagement with the practice due to panel size, increased panel density, right? We're really gonna be looking to our providers to be educating their members, to get their members excited about this, and really sort of continue to sort of create a middle ground between fee for service and Medicare Advantage, right? I really think that's the strategy of CMMI is to try and create kind of Medicare Advantage light without those what you could call punitive levers, like increased deductibles and narrow networks and utilization management, and finally. And while it may seem like a no-brainer and the most important lever for success in this program, it really is only going to be effective if you've effectively succeeded in those first three steps, right? Is your medical expense management, right? So there's a couple things, and you could spend this entire hour talking about preferred provider strategy, but essentially, while you do not have a formal network, right? Part of your strategy does need to be around working with a specific group of providers who are willing to take discounts on 100% of Medicare to make sure that for some upside on the back end, right? So essentially, they can just take a discount on their 100% of Medicare. That money then gets sent to you as capitation from Medicare. As Alan said, that can be anywhere from 0 to 100%. That's going to be really critical for being able to fund the direct contracting program. Another level that I think is so you sort of have, your specialist steerage and your network strategy there, right? Complex care management, right? If you look at the numbers, probably 6 to 8% of beneficiaries are going to be appropriate for really complex care management, right? many of those homebound and in-home complex care management. You know, it's hard to grow and scale very quickly. So one thing that I've found is that a lot of the vendors in the marketplace who do in-home primary care and in-home complex care are really orienting around direct contracting. They're all coming to the table interested in taking risk-based contracts. They understand that they will have to take balance sheet risks. So I really think from a payer perspective, it's going to be critical to align sort of your internal complex care strategy with external complex care partnerships. You know, and really the final is through the capitated payment model for participating providers. This is, you know, I worked for HealthSpring for several years, and this was really the original HealthSpring model in Texas and throughout the Southwest was, you know, capitating primary care payments with upside for total expense management, right? So they really become engaged more as air traffic controllers, right? Or more as quarterbacks of the members' care, and really less focused on revenue through the individual fee-for-service mill type activities. You know, I realize this is very high level. I'm really hitting on sort of the levers and what drives a payer strategy to think about this more than that layer down of what those individual strategies are in detail. Happy to take questions and follow up on those after the fact.
Okay. Well, thanks so much, Dave. And I know that Rich and Dave really spoke to the provider and payer perspective. I'm going to start with the requirements for entry and then talk about the sources for revenue in direct contracting, as well as some key competencies that both Rich and Dave touched on in their presentations. So what are those minimum threshold requirements? First of all, DCEs must demonstrate compliance with all applicable state licensure requirements regarding risk-bearing entities. So this is what is your capital and what is your reserve, and what are those requirements in your state. And I think it's important to remember that you might need to tolerate a little bit of operating cost loss in the first 18 months or so. That'll certainly be offset by the upfront capitation payment that you receive from CMS, but important to think about as you're considering this model. DCE must be a legal entity, though it doesn't need to be right away. There will be a separate and new tax identification number to establish that legal entity. DCEs don't have to be Medicare enrolled providers or suppliers. Obviously, the entire network does need to be Medicare enrolled, and that includes your preferred providers. And your additional competencies, we talked a little bit about adequate capital and risk reserves. Regarding your provider network, and I know both Rich and Dave touched on this, but obviously your first tactic is really to build that aligned requirement of beneficiaries. So for standard DCEs, that's a minimum of 5,000 aligned beneficiaries for that first performance year and throughout the 5-year performance period. We understand that CMS has really held firm to these numbers. So it's important to really prioritize that as you're looking at your participating provider network. A new entrant has a glide path where they start in that first performance year at 1,000 aligned beneficiaries and moves to that 5,000 mark by performance year 4. And then if you are walking into the high risk population option, you on year 1 really need 250 aligned beneficiaries, and that goes up to 1,400 aligned beneficiaries by year 4. Again, CMS is very stringent about these alignment numbers, so you want to build your network accordingly. After that, it's really about some of the things Dave talked about. You need providers that are willing to work with you and willing to improve their processes, as well as those providers that you already know are high performers that understand taking risk and that understand what it takes to really drive value. Finally, the capabilities for managing risk are critical for this model. So you want to make sure that you have strategies related to patient engagement, population health analytics, care management, which we'll talk about more, provider relations, and capitation management. Okay, so this is really about the three sources of revenue that are available to a direct contract entity. And we can talk about quality earnbacks first. What I think is really cool about this is that these quality earnbacks are built on beneficiary experience, controlling cost of care, and improving quality of life at the end of life, and then avoidable readmissions. And what's cool about that is that you don't see HEDIS in the bunch at all. And I think CMS is really coming to the conclusion that while it's important for us to push preventive and chronic care, what's more important is really controlling costs and providing the highest value for our members. So this is very important in terms of how to earn that quality withhold back in your organization. So, and the other thing to think about as you're building out, particularly your CAPS strategy, you want to make sure that you can streamline where you can. So for the health promotion and education CAPS measure, that might be something that you can do in a centralized manner. But really, that patient experience starts at the front desk of any provider's office. And so you really want to enable your providers to have a strategy that really supports the patient experience throughout their engagement with those practices. On the performance and shared savings side, really, this is all about controlling costs. When we talk about controlling costs, your biggest opportunities in this program, as aligned with the quality measures, is controlling costs at the end of life and controlling avoidable admissions. So you really, as you're thinking about this, not only want to think about your strategy for controlling costs, but also think about how your what the transparency is of your funds flow, ensuring that any providers that are participating very clearly understand how they're going to be successful and how money moves to them, as well as leveraging community-based strategies and some other novel strategies that can be supported also by some of the benefit levers that CMS has built into this program. And finally, capitated payments. CMS has been very clear in its unclarity about how they're going to calculate these per beneficiary per month benchmarks. I think all of us want to see that data sooner than we will likely get it. So our job is really to maximize that HCC score documentation as soon as possible. Consider trying to do that starting now, so that as alignment happens through claims, you can maximize your capitation in that area as well. Finally, you want to manage your referral patterns, promote stickiness in your participant providers, and we'll talk a little bit more about those strategies on the next slide, please. So success as a direct contract entity, this is really about what are those key strategies and components that you need as you're considering how best to maximize the revenue that comes from this model. So you want to think about, we'll start at the bottom here with member and patient engagement to drive satisfaction and alignment. Consider the novel ways that are already built into this model to do this. So one thing would be the small but mighty member incentive that helps drive some voluntary alignment. I think it's important to consider the cost sharing that's associated with Part B benefits as a way to, in this model, you can waive those co-payments. You do have to earn that money back in the form of shared savings, But this is certainly a way to drive members into practices that are participating. Practices can also consider other ways of engaging and supporting voluntary alignment. So social experiences that are associated with the practice, space in the practice that is devoted to education. These are all ways to really drive the right experience for that member and keep them sticking to the providers that are in the network. And we'll talk a little bit more about managing the network. Your clinical strategy is really around driving that quality through a focus on value driving programs. So as you're looking at your suite of care management programs available to you today, disease management is a great program. Does that drive dollar value to your organization? In this case, it might not be your top priority. You might really think about admission avoidance programs, transitional care management programs, programs that focus on palliative care and end-of-life care. That might be the place where you get the biggest bang for your buck on the clinical strategy side. We think that there's opportunity in composing an interdisciplinary network, not just driving outcomes on the PCP and specialty network side and your preferred providers, including hospitals, home health, those types of providers, but really consider engaging community-based organizations to really address some of the social determinants of health. Community-based organizations are open in some cases to some type of risk-sharing arrangement where they maybe have a payment withhold in exchange for performance on particular quality measures that are established by the DCE. So it's important to consider some novel ways to build out your network. Regarding network management, on the preferred provider side, so we talked a little bit about your participating providers, and really biggest bang for your buck on your participating providers is making sure they're bringing the right number of aligned beneficiaries. When you're looking at your preferred providers, you really want to look at what are those referral patterns in the community where you're looking, and can you use a strategy for risk-based contracting that then supports preferred providers with additional paybacks on the back end. Data sharing is of course key to success throughout this model. And you really want a range of tools, right? You need a pro forma that you can game out some of those strategies that you're thinking of. How, if I spend this much on care management, I can expect this much in terms of revenue coming back to me. If I look at my provider network, you really need a tool that helps you identify those best performing providers and identify the referral patterns for different providers. Other tools from an analytics point of view, obviously you need a population health management tool and other analytics that are going to support you in risk contracting. And finally, governance. You really want to try to leverage any existing government model that you have today. So existing ACOs, clinically integrated networks, IPA governance models, those are great. As much as possible, you want that model to drive transparency. And I'm going to pass it back to Alan.
Thank you so much, Lesley. Can we flip to the next slide, please? So as my junior high math teacher used to say, so what should we be really thinking about today? So some of you may be launching April 1st. You already applied, you're in, hopefully you met the attribution requirements because there were some bumps in the road there, and we can talk with folks about that if they have questions about the complexities of attribution and where the pitfalls are. But you're in, you're starting, right? So what are some of the key things that you need to think about? I think whether you're starting April 1st or whether you're looking at starting in 2022, and the answer is yes, we're hearing that Medicare CMS is likely to have an application come out. It's likely to be a bit of a fire drill, so it'll probably come out late in the spring. There'll be about a month to apply, and then it'll be due. So it is important to plan now. one of the things everyone should do is take a step back and remember that these demonstrations and pilots and other types of programs that come out from the feds and the states, they often really are very exciting, very positive opportunities for you to build your business, to build your ability to manage and risk, to grow your population and market share. That said, you don't want to have the tail wag the dog. So the first thing to do is assess your current state in terms of where you are as an organization and clarify what are our goals. In other words, what populations do we want to have under management? How much of the premium do we want to be responsible for? What parts of the care continuum and costs, what we call the MLR, medical loss ratio, or the DOFR, the Division of Financial Responsibility? What do you want to be responsible for and manage actively and have the benefit or the downfall of the results from? What do you want to do with relation to your network? What kind of network do you want to have? Who do you want in and out? And what level of risk are you willing to take? And so if you do that work first, it's so much easier to line a program up like this up with what you are doing with your overall strategy. So have a strategy. You want to make sure, and everyone said this, I think, having a really well-informed pro forma. You can start with top down. If you have, for instance, shared savings data on membership is likely to be attributed, you can use that for a nice bottoms up pro forma. But really want to understand the drivers of revenue, ROI on various interventions you're going to put into place, those kinds of things. You want to understand any need for reinsurance. There is the CMS reinsurance in the model. There's also private reinsurance out on the market. Folks like Aon have lots of experience there and are looking to talk to folks and help them understand what they need there. You want to make sure you align the funds flow that you put together for this, again, with your other value-based payment arrangements so that your physicians and any other providers you have engaged in risk with you really do have the same incentives right across their various populations so that you're managing their panel with them, not a bunch of different payers. You want to make sure that you have physician level performance data to put in front of your doctors and the actions they have to take to improve performance. And then another important thing to think about, again, this could be a gateway to MA and other forms of payment. So whether you do standard or new entrant, or maybe you're doing high needs, you want to have one or more aligned Medicare Advantage, PACE, DSNP, or related products available so that the beneficiaries in your program, if they do want to join a program like that, you have one that's aligned with you where you can still access premium, you can still align your doctors, and you can still engage with beneficiaries. So those are some key considerations. We're really tight on time. We've got about 3 minutes left. So I think I'm going to, there are lots of questions that have been sent in. And also that have come across in emails and other things. So I think I'll ask a couple of quick questions, if that's okay for folks. We'll see what we can get through. I'm going to start with Lesley. Lesley, do you mind answering a question that came in? And the question is, how do you make this successful, knowing that members can go wherever they want? I'm paraphrasing in terms of out-of-network. I'm just going to take that part of the question because we're tight. What are some of the things that you would say folks need to do to ensure success in an open network type of program like this?
Sure. Thanks, Alan. And thanks for that question. I think first, use the levers that are unique to this model. You have some small incentives that you can share with the members. You want to make sure, again, that you're supporting providers in creating that successful sort of happy beneficiary experience. Take the opportunity to waive those copays on Part B services. And then we did talk a little bit about other strategies. So social experiences, educational experiences, anything you can do to bring that member into the fold of your provider practice is going to help that provider member be a little stickier to the provider's practice.
Thank you, Lesley. And with less than 1 minute to go, I'm going to say thank you. I want to say thank you to Rich and Dave and Lesley for taking the time to talk with folks here, and obviously to our audience. We really appreciate having you. So again, we'll be sending you all a copy of the tape. We will also have a PDF of the PowerPoint, and we'll have all of the answers to the questions you submitted sent out to you as well. So thank you all so very much. Enjoy your day, enjoy the beginning of spring, and we hope to talk to you all soon.